Okay, so this is an MR of a young female, axial T2 fat set images. This is in and out of phase. This is
So we have like a
pre-contrast T1.
very fatty liver with sparing of those lesions that seem to be enhancing.
Yes, and this is the arterial phase. Don't know the... So just wanted to know everybody's thoughts on this. Yeah, it's nothing complicated. And we also have EOVist on this patient. We gave EOVist. So these are the 20-minute delayed images.
So they seem to be retaining on EOVist.
Yes, no obvious like washout. There was this one area that I would like to bring everybody's attention to, like in this one probably looks like the largest focus of abnormal signal intensity. For obviously our differentials here are like whether we are looking at just areas of focal fat sparing. So we try to look if we have normal vasculature going through these lesions. This one looked like a little mass, like with some bulging contours.
Given that EOVist retention, I'm thinking FNHs in a background of fatty liver. Before you showed that EOVist, I was thinking adenomyomatosis in a background fatty liver.
Yeah, so that's the confusion that we always have with these cases when the background liver is so fatty and we have these middle-aged or younger females who have this diffuse hepatic steatosis and you have these multiple lesions and you're not, like, at least we sometimes get confused whether we are just looking into focal fatty infiltration or these are multiple hepatic adenomatosis, like this is hepatic adenomatosis. EOVist, but yeah, EOVist, if, I mean, this is probably the theory that I like, that if they retain EOVist or they don't show washout, this was probably just focal areas of fat sparing. And if they wash out and they're like true lesions, that means there's no normal liver parenchyma in that area. That means they're adenomas in those areas. But sometimes it's hard to differentiate, and that's why I brought these cases to this conference to see if you all had any other thoughts, or is there any other definitive way to prove one over the other. And there's this one more case.
Yeah, Gitanjali, I think that's a really good challenge. I mean, this is a great challenge case because it, for example, is it FNH? Are they multiple FNHs, or are they nodular fat sparing?
Yeah.
And I think actually, Victoria, do you have, Victoria says she's here and she has cases. Can you pull that last case back up and maybe see if Victoria has any comments?
I'm sorry, the meeting ran over.
No worries. She was just showing this, well, Gitanjali, you can present.
Yeah, so yeah, young female, this is the T2 fat SAD. Really don't see, like maybe some subtle areas of hyperintensity in the liver, but you see obvious abnormality on this in and out of phase images. This is in phase, nothing much. Out of phase starts showing background liver to be very fatty. And then there are these areas of either sparing or if there are any lesions here. This is the pre-contrast T1 fat SAT.
Do you have EOVist?
Yes. This is the arterial phase and we can see some enhancing foci, and this is the EOVist 20-minute delayed.
So we're
real
debating
washout.
Like this makes it look like FNHs, but how could you differentiate that from nodular fatty sparing?
Well, you can't. I guess the only suggestion, the larger FNHs probably, are more likely to have central scars than not. Also, if you look at subtraction and see like if on the arterial phase, if there's real hyper enhancement, or it's just like a little higher signal because of the fat suppression of the background. Now we have a very similar looking case See, so this is arterial phase, right? Subtraction. So this,
Yeah, this is
right. So then there's no hypervascular. Well, okay, here's that.
this is arterial phase subtraction. Yeah, not a lot of
I guess in the end, it doesn't really matter because
it doesn't really matter.
Yeah.
The only thing, like, look, there also almost looks like on the portal venous phase. Look at the subtraction of portal venous phase. Subtraction. It almost looks like there's washout, right? And
Yes.
we just had a case very similar to this, almost identical. And this was a woman with multiple adenomas, and like most of them look exactly like that, including kind of ISO enhancement on the hepatobiliary phase, except for one. One was clearly hypo-enhancing. So I would not necessarily discount, rare adenomas from the differential.
So Victoria, that's a good. So recently, like some papers have been saying that there's probably more inflammatory adenomas that retain EOVIS than we realize.
Probably not to this beautiful uniform extent.
Yeah, that's what I was wondering. Like usually those adenomas aren't so homogeneous, right?
Right, but let me see if I can pull up the case that I'm thinking of.
Yeah, and I have a couple cases, like similar cases, and this one is biopsy proven. So I think they didn't believe that this is fatty sparing, and they went ahead and biopsied this larger area here, and this turned out to be just steatosis. I mean, fatty, like background liver at steatosis, and the other areas of sparing. And then the other case that I was showing is this, very similar. Again, on all, these are all females and age group of 40. This is the haste. Again, we see definitely some lesions here which are T2 bright. This is in and out of phase. It's on the other side.
So this almost looks like the background liver is fatty, but then these nodules are also fatty, like even fattier.
Yeah, there's no difference in the signal intensity between the nodules and the background liver. Again, we give EOVIS, so we get this lot of breathing artifact from that, and really not showing a whole lot of arterial enhancement, but there are definite lesions in the liver as seen on this portovenous phase. And I'll keep moving on till I get to the delayed. Yeah, and this is EOVIS, and in this one, you see them, all of them washing out on this 20-minute delayed phase. And again, these ones are also biopsied, and this one is adenomyomatosis. So my theory was, like, if EOVIS really helps in differentiating the two conditions, if you see washout, these are adenomas. And if you don't see washout, it's uniform liver on 20-minute delayed images. It's just fatty liver with areas of fat sparing. I don't know if everybody agrees with that. I've not seen any papers talking about this.
Yeah, so a couple of points here. This is actually more of a wash-in of the liver than washout of the lesion. So yes, it helps that way. And the other thing is that when you look at the EOS scan, that typically is very close to the opposed phase echo time. So so when you're looking at fatty infiltration, like your last case, Gitanjali, that basically had some dropout because you are very close to the opposed phase imaging. So my suggestion is to, again, do like an in and out of phase post EOVIST, like 20-minute in and out of phase, to figure out what's going on.
Yeah, we've discussed that. We'll probably try it and
try it out, and that probably
see if that makes a difference. And so I'll bring up the case that we just saw yesterday.
Gitanjali, but about your other points, I think that makes sense to me. You know, about the focal. That was really cool that you had biopsy proof for that first case.
Yeah,
they really do look like masses, and then with the retention of the EOVIST, I think I probably would have just jumped to like, these are FNHs, you know.
Yeah, the other thing with FNHs, that is another differential, but you always see, again, like some signal change on the 20-minute delayed. Like FNHs tend to take a little bit more EOVIS than the background liver.
Yeah, you
I don't know. This is again an observation, again, not really proven, or we can like see if there are more papers on it. But this was another case that we saw yesterday. There was the CT, and Again, same, I think she's also 40-year-old female, had this background fatty liver and has these areas of exaggerated enhancement in the periphery. And here, like whoever read this report confidently said that these are areas of fat sparing. She also had pancreatitis, and we often see areas of fat sparing in patients who have fatty liver and pancreatitis. And then this is the MR, which again shows very fatty liver. And then one of these lesions has a cystic transformation. I think there's some degree of hemorrhage also within the lesion. This is the pre-contrast T1. There are multiple nodules which look T1 bright. This is the arterial phase. Again, looks like there are arterially enhancing lesions. So can't tell if these are areas of fat sparing or just because the background liver is fatty and it drops signal on these arterial phase images. And then this is the diffusion, and because of which I thought that there might be some hemorrhage in these lesions. So if this was just focal fat sparing, as we called on CT, like then what is the, we didn't have EOVist on this one, but then the discussion is then what is the explanation for one of like an area of cystic degeneration or hemorrhage developing within the liver. So probably these are adenomas on the background of, and adenomas are known to bleed.
Do you think the pancreatitis is related to this fluid collection? Like it could be some kind of abscess, or is there?
Yeah, probably, but it didn't show any, like an abscess would show a lot of peripheral hyperemia around the lesion. Didn't see that. And if you're thinking of like, if you think of a pseudocyst migrating and coming, but then it should come from the liver capsule and that insinuating, like probably in the subcapsular location, wouldn't expect that to get into the parenchyma.
So Gitanjali, you're saying that in the end, you guys decided these were focal fat sparing, but then one of them was an adenoma that bled.
No, I think then these other lesions are also, now this patient probably has adenomyomatosis given the background fatty liver and her demographics of. But in this one, we have recommended that we'll do a follow-up with EOVist sometimes later, maybe in 6 months, and see if then we see, do all of these lesions show washout or some show, I mean, there could still be areas of fat sparing in this, yeah, no doubt. But then given that one lesion probably degenerated or bled, the hypothesis would be that these are probably adenomas, multiple adenomas.
Yeah, this is another kind of diagnostic conundrum. Basically, it can go either way. Had it not been for this necrosis, we probably would have called maybe even fatty.
Yeah, we would have we would have just called it fatty liver.
Now, yeah, either we call everything as adenomyomatosis and one bled and had cystic degeneration, or entertain possibility of two different lesions. One larger one is the adenoma and the others are focal fat. So we have called this patient back. So let's see what we get.
Cool, I like the series. But yes, it's a challenge.
So it's a challenge. My other question was, we see this so many times, like fatty liver, areas of fat sparing. So is it like develop a criteria if you see it in that age group, females, maybe if they're on NOC pills, then you like, do we recommend MR in all cases to see if like how many of these are actually adenomas or just areas of fat sparing?
I don't know, because unless you biopsy them, I mean, we don't even have proof that they're not just fat, poor adenomas.
Exactly, yeah. In 2 cases, I was lucky to get biopsy, but yeah, in other cases, yeah.
I think it may be like if it's a large enough lesion that they would actually do something about it, then it's worth biopsying.
Yeah, if they're small, they can just like I have like now 7-8 cases, and they all look similar. Some we are just following it up, and some have EOVist, so we know what they are, or maybe we can hypothesize what they are. And 2 of the cases are biopsy proven. So
yeah, it's tricky.
Yeah, but I don't know. I personally feel EOVist is a good way to sort out what it is. FNH will be slightly hyperintense. Fatty liver is ISO on 20-minute delayed, and adenomas will show washout. The adenomas that retain EOVist, as Victoria said, they will always not be like very uniform. They will have some heterogeneity associated with them. So I think that's a good way to differentiate. but that's still just a hypothesis.
And David is saying that contrast
enhanced ultrasound. Yes, we don't use that extensively here, but that should be a good way to figure these things out too.
Cool.
That's all I have.
Okay, David, do you want to go next?
Sure. Just make sure I'm not showing any patient information here. Okay. All right, able to see my screen?
Yes.
All right. For right now, history is withheld because it's kind of an Aunt Minnie, especially if you know the history. But history of left submandibular gland swelling, fluctuating in size with antibiotics. So this is a side-by-side of the submandibular regions, left and right. And then this is the palpable area within the substance of the submandibular gland.
So it looks like there's multiple lesions, one of which is larger.
Yes.
And the only thing I can think of for multiple lesions in the submandibular is like IgG4, but I don't know that much about the submandibular. Tarun is asking if there's a history of HIV.
Yes, there is. Actually was newly diagnosed 3 weeks ago.
Epithelial cysts.
Yes, lymphoepithelial cysts, usually seen in the parotid glands, but it's in this case seen in the submandibular gland.
Classic with that history.
And then anyone guess what this was when we biopsied it?
Maybe complicated by lymphoma?
What was that? I didn't hear, sorry.
Lymphoma?
Yes, B-cell lymphoma.
Nice.
So first time I've seen it personally in the submandibular gland. Usually we see these in the these little hypoechoic, innumerable, somewhere appearing foci in the parotid glands, generally attributed to lymphoepithelial cyst of HIV. Can also be seen in IgG4 and Sjogren's syndrome. And I know our ENT service is always asking us to biopsy these because of the risk of B-cell lymphoma. Unfortunately, usually these things are so tiny we can't get any material out of them. But it just so happened that this one was dominant and was palpable, and we were able to get a core needle in it. So we just had that last week.
Very nice, thank you. Victoria, you wanna go?
Can you hear me? Can you hear me? Yes. Just get seconds to share screen. Oh wait, share screen and then this. Sorry. Okay. So I'll just first show quickly the case. It's similar to Anjali's. This is actually a very interesting case, not diagnostically, but kind of management-wise. So this is a very young woman. She's like in her late 20s. So you can see, she's not, she's body habitus, and she's been, she has polycystic ovarian syndrome. So she's been on, OCPs for like 15 or 16 years, something like that. She's not married, she has no kids. So you can see that her liver is quite fatty. You can see that very similar to Angela's case. We have these rounded areas. Some of them actually almost look like they're not masses, right? But they look very, very similar to what you had. This was on the you can see again, because the steatosis is so severe, the background parenchyma sat out, so you see these kind of areas as kind of standing out, but that doesn't help us to figure out if it's a mass or not. So on arterial phase, again, looks very, very similar to what you had, kind of slight hyperintensity. Notice that this one lesion kind of looks slightly different from others. And just to show you what it looks like on hepatobiliary phase, you can see that in general, the liver is not as bright, let's say, as your cases, right? So there's probably some sort of degree of steatohepatitis on top of this. And you can see most of the lesions do retain contrast. So they're not perfectly homogeneous. They are slightly heterogeneous. Maybe smaller ones, a little more homogeneous, but the bigger ones are more heterogeneous. And notice this one lesion in particular does not concentrate either. So with these imaging appearance, we're kind of strong, and with this history, we're strongly favored adenomas. And then I think that this adenoma somehow is different, like on its immunological or whatever, its genetic profile is different from the rest of them. The interesting part of this patient is how to handle these, because I think this one was like 6 centimeters, something like that. And so once the adenomas get this big, they need to be treated, either resected or embolized, for the fear of bleeding, particularly if the patient is planning on getting pregnant. On top of the whole thing, patients should stop OCP. But in her case, she really can't, because she has, polycystic ovarian syndrome, so she's taking OCPs for that. So it was like a very interesting discussion of how the management of the patient, like how to manage this patient, because she really can't get off the OCPs, but then she has to, because there's also a risk of malignant transformation, everything. Anyway, so this was an interesting case to complement Angela's.
Yeah, it's a cool example of retention on the EOVIST.
Right.
But like more heterogeneous retention.
Right. But also it's very interesting because, again, in the same patient, the same, the same environment, this patient developed, very distinct adenomas. I mean, I don't have a path, but you can see that they behave quite differently, these two things. All right. So the next person is a young woman. She's pregnant, little baby, and she had this abdominal pain. She has right low quadrant pain. Her ultrasound wasn't really conclusive, so they got an MR. And on MR, it was not clear if we saw an appendix. Here was the ovary. We thought maybe this is the appendix. It was very difficult. She's very skinny. But we thought that possibly this is the appendix. It wasn't dilated, but then we thought, well, there's plenty of studies that show if you see fluid in the appendix on MR, it's very suggestive of appendicitis. But then there's really there's normal caliber. There's not much in terms of, specifically inflammation around this structure, but there is focal inflammation in the right low quadrant. She had pretty severe pain in the right low quadrant, so we kind of hedged and said, well, on the basis of this exam, this is equivocal. So she was fairly sick, and or whatever, she's not sick, she was fairly in a lot of pain, so she had her CT, even though she's pregnant. And you can see that here's a contrast feeling the appendix. So the appendix was clear, there was really fat around it, was pretty clean, so no appendicitis. So, I was about to close the case and just decide whatever. Then you can see here's the right gonadal vein, so go down, and then it becomes non-ossified, and it goes right into this ovary, and you know, when we compared the two veins side by side, right? Because first I was like, I don't know, maybe it's just, you know, just non-mixing or something like that. But you can see that you know, this part of the gonadal vein next to the ovary is not ossified, and then the left gonadal vein is perfectly ossified throughout. So if this was some sort of admixture, maybe there was like reflux into the, you know, the gonadal veins, then it would have been symmetric. So it seems like she has a gonadal vein thrombosis. Another interesting part is that look at the right ovary versus the left ovary. You can see that the right ovary doesn't quite enhance as much as the left. And another thing is that the location of the right ovary between the two exams is different. So this is conjecture on the part. So she definitely has thrombosis of the gonadal vein, or partial thrombosis of the gonadal vein. But I suspect also she has some sort of either partial torsion or torsion-to-torsion situation, and that may be the reason why this part of the vein is thrombosed. I don't have a proof for that. They just put her on Lovenox, I think, and let her go.
Victoria, this is Manjul. I mean, perhaps the ovary's torsed, and that's why there's no drainage into the gonadal vein, or it's slow filling, or perhaps it's mixing slower than it would otherwise.
Right, that's what I'm saying. I thought because the location of the ovary is different between the two exams. I think there was a 2-day difference between the studies. You can see here from here to here. So because of the difference in location, and because, you know, you can see that there's differential appearance between the ovaries. This ovary is a little less prominent and is kind of enhancing better than this one. So I suspect that this thrombosis is related to either partial torsion or torsion to torsion, but I don't have a proof for that.
Yeah, I guess that's what I'm saying. I don't think the gonadal vein is thrombosed there. I think that it's just not filling completely because the gonadal vein is draining from the ovary on that side mostly, right?
Right, but there's really no twisting at this point, right here, right?
I think
I don't know.
Ovary looks suspicious for torsion, for sure. I mean, the location is one thing, but also it's edematous and doesn't
Right.
look good. So then that ovary is not going to be draining blood into that vein as well. You know what I mean?
Right. So
then, you know, there's unopacified blood going through there is my sense.
well, yeah, except for, you know, so then, okay, so you have to accept, right? So it's this part is ossified, right? So if this part is ossified, that means that there is reflux, right? Reflux, agree?
Exactly.
So which means that then if this is reflux, then this has to be thrombosed, right? There's no reason why, if this was patent and it was reflux, it would not be ossified. On the other hand, if, you know, or if the blood going the right way, then again, there's no ossification here. Can
we see the axial again for that, Victoria, on the CT?
Say it again?
Just the axials on the CT again.
There. There's really no, I was really looking for twisting. There's really no twisting. The ovary, here's the left ovary.
Yeah, that one looks good.
So, yeah, so I mean, I suspect she had some sort of torsion situation happening.
Yeah, I do too, but I'm dubious about the gonadal vein stuff, though. I feel like, you know, sometimes, and it's also, there's a pregnancy there. There's.
Do you have arterial phase on the axials?
No, this is it. No.
You know, it's always like this.
This was obviously not, this was done just for appendicitis situation. So you can see, here's another thing. So here's the BTFE, right? You can see that the vein was much smaller and it was patent, fully patent. So there you go.
But the patient was symptomatic on the MRI too, right? So like,
yeah, patient was patient was symptomatic. So CT MRI was done 2 days before CT. So she's been symptomatic enough to be admitted to the hospital and stay in the hospital for 2 days, and then for them to just go for CT because MRI would not be conclusive on MRI.
So is the thought that the gonadal vein thrombosis like developed during her symptomatic period within these 2 days?
Probably. I mean, I suspect there's torsion, some sort of torsion to torsion.
That's what I think. Yeah.
I mean, it's possible that you're right, that this is just an inflow situation, but whatever it is, I think that she has some sort of torsion happening. Yeah. They just kind of assume that she has thrombosis and they discharge on the lymph.
One quick thing about gonadal vein thrombosis. I had a couple of cases recently where like we incidentally found them. This was not in like pregnant patients or young patients where it's more common in pregnant patients. But, and so I was kind of looking up like, what do they do about gonadal vein thrombosis? And it sounds like it's still controversial and it's not necessarily, treated with anything like, and it's not necessarily better to anticoagulate or anything. So even if it is a gonadal vein thrombosis, I guess, if that was the only finding, I guess they would probably just treat it conservatively.
Right. The only time that the gonadal vein thrombosis is treated, like with what has to be treated with anticoagulation, is in a postpartum setting, because patients will continue to spike fevers for whatever reason.
Cool.
Yeah.
I wish we had an MRI at the time the CT was done. That would have been a really nice ovary to look at.
Yeah. The wishes that we have. All right. So the next patient is a I guess missed difficult call category. This was an older woman. She had chronic pain. She had an ultrasound. You can see that. She has thickened wall and a lot of stones and regular stone. She had an ultrasound. She had an MR prior to cholecystectomy because they were looking for cholecystitis, and she had some. At the time, we saw, the gallbladder was, kind of full of stones, and that's pretty much what was said about it. And the patient had her.
It looks a little irregular, Victoria. Like.
Yeah. Did they read fundal adenomyomatosis or?
Well, I don't think they did. I think they just said chronic cholecystitis. I know what happened to the patient, so it's hard for me to, to be not biased, but it's a very good chance I would have just passed it as an adenomyomatosis, even though we really don't see, I'd like to see T2 hyperintense foci to be definitive.
Do you have a coronal, so that we can look at the fundus?
Yeah. So you can see this right here. Using nice cholecystititis.
Did it enhance at the time, Victoria?
It did.
Yeah, to me, it's looking more evil grayish, like either chronic cholecystitis or cancer.
So, right. So here, this is it on the. You can see, kind of enhancing. And again, it wasn't called, prospectively. I sort of, kind of. It's not a horrible miss, but.
Well, I don't think it's a miss, Victoria, if it's addressed as adenomyomatosis, honestly, because more times out of not, that will be adenomyomatosis. I wouldn't pass this myself, but it's not a miss to call this adenomyomatosis. That's a difference in, opinion or whatever.
I don't believe it was called anything.
Then that's a miss. Then that's a miss.
Let's see. No, it just said contracted gallbladder with multiple gallstones. Yeah, so yeah, and then diffusion wasn't very helpful. This is one of our oldest scanners. It's questionable if this truly is restricted diffusion now. Anyway, so you guys kind of getting where it's going. This came out, gallbladder came out, and of course this was early gallbladder cancer. So I went back and looked at it again, like this kind of peak-looking thing. We see that with adenomyomatosis a lot. But again, the fact that there's not a single intramural cyst, I think that should raise a flag that this is not, it can't just be. Theoretically, still could have been adenomyomatosis, but I think that at least a suggestion that this could be early neoplasm. So the patient had to go back and get wider resection afterwards, and they're trying to figure out if she needs chemo.
Is there a node or some deposit near the fundus on diffusion? Is that a separate?
Okay, can you say that again?
Is there a node or a deposit in one of those images? Yeah, go back on the diffusion. Right there. One more. The other way.
This?
One more. Yeah, that one.
No, this was part of the thing. Again, it's not our greatest scanner. It's actually one of our least greatest scanners. So some of it is difficult, but there were no nodes. I think whatever. There was no local extension, but and then when they went back and did the wider resection and did the full thing. There was no node. So it's truly very early gallbladder cancer, which for this patient, she's very, very lucky. It was discovered at this early stage. So.
I have a question for Manjul.
Oh, hi.
Hey, I think I met you at RSNA. Nice to meet you again. So I wouldn't have thought of adenomyomatosis here because I think of adenomyomatosis like having cystic spaces.
Of course.
But you feel that like it can also look like this?
I mean, my sense about this is luminal narrowing of the gallbladder is worrisome, obviously, for cancer. I mean, you have to be concerned about a mucosal process. On the other hand, most cases of adenomyomatosis, yeah, they have cystic spaces. There can be some of a waste there. This doesn't really quite look like that. I was just trying to explain maybe what the radiologist who interpreted this would have done. Like I said, I wouldn't have passed this case, because what you said, there's no cystic spaces. I think also typically with adenomyomatosis, you see either the lumen running through that period, there's not as much mass effect, or perhaps there's a little bit of lumen after the segment that's involved. And this didn't have any of that. But I was just thinking, for the radiologist who read this study, I could see how in a moment you decide that's adenomyomatosis and you continue,
Right. Well, I think that, yeah.
And then I guess also common things being common, adenomyomatosis is extremely common. So, my eye tends to go toward that way. But like I said, this case, I wouldn't pass it for adenomyomatosis. I would have at least recommended an ultrasound. And the other thing I was going to ask is, Victoria, don't you think that based on the ultrasound appearance, maybe the wall is even calcified here and we just couldn't see it,
It could be, but it's not,
Well, we have a CT. Oh, was that after?
This is, let's see. Yeah, no, that was after. Yeah, no, but now they're saying, I guess David, David is an ultrasound, a far greater ultrasound expert than I am. Would you call this calcified wall, David?
No, and really for adenomyomatosis, you want to see the comet tails. And ironically, guys, I have open a gallbladder case from our county hospital that is identical to this. Mm-hmm. But they equivocated on the CT, and I now have my colleagues beaten into them that if they see on any modality what could be tumefactive sludge versus adenomyomatosis versus gallbladder mass, they come to contrast-enhanced ultrasound. And I literally was just sent the images from the contrast-enhanced ultrasound. Unfortunately, it's not anonymized, so I can't show it to you. It has the patient data burned into the ultrasound images, but it clearly shows a polypoid avidly enhancing intraluminal mass in a 60-year-old. So it's a gallbladder neoplasm, slam dunk. So I think differentiating tumefactive sludge, adherent non-calcified stones from gallbladder cancer is super easy by contrast-enhanced ultrasound because our sensitivity for blood flow is so exquisite that we're not having to equivocate on Hounsfield unit changes or subtraction images. So I implore you guys to consider that, contrast-enhanced ultrasound in these difficult cases.
You for us?
Can I ask a question about that real quick? So this is Manjul again. So what's the workflow for that then? Does everybody in your group do that, or do you guys schedule it on someone's day, or how does that fit in with the remainder of ultrasound?
It's obviously really dependent on everyone's workflow. And of course, we did start with just a few cases a month that came on, my day on ultrasound. But now we have, probably about a quarter to a third of our abdominal ultrasound sonographers, radiologists, and all of our ultrasound radiologists at least comfortable with obtaining images and checking them for quality. And then if they can't figure it out themselves, they save the images and call me up, which, I'm reading this one remotely with one of my colleagues over at the county hospital while I'm here at the university side. So And we have a critical number of sonographers that are able to, you know, mix the contrasts, you know, set up the software and obtain images. So obviously it's been a multi-year process to get to this point. But you got to start somewhere, right? You're going to have some growing pains as your volume increases. But I drag other radiologists and other sonographers into cases with me to teach them how to mix the contrast and check the images for quality. But as far as workflow, you know, it's fairly easy for ER and inpatients because you have kind of time on your side. For outpatients, a little more difficult, but we do have sonographers who are really good about shuffling the schedule around and making room to bring the patient back into the room after an IV is placed to, you know, characterize an incidental liver lesion or renal lesion, or, you know, check if a vessel is thrombosed or not. So,
yeah, thank you.
Let me see if I can pull up one set of images and hide the. There is a way for me to just do a part of a screen, right?
Yeah, if you go under the share screen advanced, and then you can just focus. Yeah. So why don't I stop sharing? I have more cases, but you know, we can do them later.
Okay, share screen.
And then just make sure you're on the advanced setting, the box is just over the part you want to show. It'll be like a green box.
If I right click on, oh, advanced, I see it. Point of screen.
That's cool. I didn't realize that you could just like take cines and then, you know, do teleconsultation. Seems like that might be the future.
Yeah, we're on two different PAC systems, but fortunately the hospitals allowed us to unlock the PAC systems enough to where we can load both PACs on both systems on both sides of the fence. So anyway, so this is the CT out of the ER. It's not scrolling great, but here we have some stones in this, it's probably a Phrygian cap, and then kind of this, you know, is that more stones? Is that solid enhancement on this single phase CT? You kind of get a sense there's some asymmetric wall thickening here.
Was this the case you were talking about with the question adenomyomatosis? Yes, at the waist, right? At the body? Okay.
Kind of this wasting, and then this, you know, Phrygian cap with some stones. So, you know, it could be very, very well be just, you know, collar adenomyomatosis here. I'm going to gingerly pull this ultrasound over. Forgive me.
Victoria, are you guys doing contrast ultrasound at Monty?
Well, yes, we have capability, but
Same.
on this we have not done a lot, unfortunately.
Same. For us, it's mostly a workflow issue. Like, we have to figure that out.
Yeah. David, maybe you can give us grand round or something.
Sure.
All right, I'll get in touch with you.
All right, so this is kind of a long image of the liver here. This is the gallbladder, and it's, again, flopped over. So what's in the middle here is kind of that collar. Mm-hmm. But what my colleague is focusing on is this area here, which is that soft tissue in the inferior aspect of that gallbladder fundus. So keep your eye here on the contrast mode image as we scroll, and you start to see some arteries fill in the cystic artery and then the hepatic arteries. And then here you see that florid enhancement of this kind of polypoid looking lesion along that narrowing, that wasting of the gallbladder. So all this irregular thickened soft tissue and this polypoid mass.
Wow, that's
so
nice.
I'm on the phone with surgical oncology right now, telling him, don't let this general surgery take this patient. So.
But also it shows the degree of tumor that's inside the lumen as well.
Yeah, and so we've actually used this to verify whether or not there's an invasion of the liver. You know, this looks pretty, I'm going to interrogate these images a little bit better, but some of this lobulated stuff against the gallbladder, gallbladder fossa is a little worrisome. So, but obviously our surgical oncologists are going to take this patient and do a en bloc wedge resection of the liver to scoop out anything. But, I think this is here's those stones here. So you can see the reflection off the top of the stone and all the shadowing. So you can see what the stones would look like on contrast ultrasound, and then what the polypoid mass looks like. So we've been doing this more and more right out of the ER, and it gives us the definitive diagnosis. You can see little polypoid projections. So
cool. This could even be an ICPN, an
could be.
infectious cholecystic papillary neoplasm.
Yeah.
How like friable it looks. David, I have a question for you. For adenomyomatosis, how it can enhance, I think because of the muscular hypertrophy.
Mm-hmm.
Would you, on contrast enhanced ultrasound, do you see like kind of a different pattern of enhancement where you see if like you have a dense adenomyoma, like in the fundus or something?
Yeah, that can be a little more difficult. But if I see, I usually combine the features between the contrast enhanced ultrasound and the grayscale. So if the grayscale is showing classic adenomyomatosis with the areas of ring down artifact, then even if there's wall enhancement, I'm not too worried as long as it's kind of smooth. But obviously there's no ring down artifact here. There's some stones, but you're not going to get like these polypoid projections that you would in adenomyomatosis. So yeah, there can be some robust enhancement, but with the combination of the grayscale features, you can usually tease that out.
David, can I ask a question too then? So
Sure.
Am I understanding that perhaps then the contrast just adds some degree of like contrast subject resolution to better identify the mass? Because I don't think that I would, I'm not sure that based on the degree of enhancement that I would say this would be one or the other, right? So like what does it add to the grayscale image?
Well, the grayscale, obviously the contrast gives you information about perfusion, right? So it obviously delineates the lesion a lot better. I mean, that's why they use it in cardiac imaging. But if this was sludge, inspissated bile, tumefactive sludge, none of this would enhance. You wouldn't see it.
I got that part. I was just saying like between adenomyoma versus gallbladder cancer, like that's the question that we're facing all the time, and like.
Oh, well, I think it's just based on size. Right, so this is clearly over a centimeter. This is going to come out.
Yeah.
And if you see it directly growing into the liver, obviously, then you have your answer. But
I don't. The resolution looks much better than that.
Yeah, the resolution is definitely better because it adds more contrast. Like just like in CT, contrast adds resolution, obviously, and there's subject contrast. Then, like there is a difference there. It definitely adds more. Like you can see concept acuity of it much better.
That's so cool. You had an immediate companion case.
Like literally, I was paged 5 minutes before you guys showed that other case. So, so yeah, good troubleshooting tool. Anyway, I got to go to biopsy. So you guys take care. All right.
Thanks. See ya. Okay, I'm going to show just a couple of quick ones. Okay, this is the first one. So this was a young woman, and we can see that there is peritoneal nodularity here. She was actually in her mid-30s, and so this was kind of a surprising finding. And immediately you have to look at the stomach, pancreas, ovaries, and appendix. So the stomach looked fairly normal. Pancreas looked normal. Ovaries looked fairly normal. And then the appendix, we couldn't really see well. Basically, this was the terminal ileum, ileocecal valve. And then did not find a normal appendix and kind of found some nodularity down here. So said that we were suspecting, and then some lymph nodes here. So we said that we are concerned that there is peritoneal carcinomatosis and that the appendix may be the primary culprit. And that's what it was. She ended up going for cytoreductive surgery, and they removed all of this, and it was a high-grade appendiceal cancer. In retrospect, she had had some pain a couple of years ago, 3 years ago. And you can see this is the TI here. And then this is the origin of the appendix here. And then this is the remainder of the appendix, which was fluid filled, but did not have any stranding around it. So I guess, you know, in retrospect, we can say that this sort of soft tissue here and this dilation of the appendix here was probably the beginning of that appendiceal adenocarcinoma, but we didn't really detect it at that time. And then actually this was, what'd you say?
The mucocele.
Yeah, well, that's actually a little bit of the point that I was talking about with my fellow. I'm not sure that this is a mucocele versus obstruction of the appendix by this adenocarcinoma here.
Was it mucinous at path?
So the path is actually goblet cell with mucinous features. So yeah, at this point, we can't really tell, like, was this a mucocele or is it obstructing it and then causing this kind of like just accumulation of fluid? I guess if it was truly obstructing it, we would see more inflammation. So this could be a mucocele. I'm going to talk a little bit about like the different mucinous tumors and stuff. But do you think you would have called this a mucocele here?
I would have, yes.
Okay. I was thinking.
I would have said fluid-filled appendix without periappendiceal fat stranding. You know, is atypical for appendicitis, and there could be an underlying mucocele. You know, mucinous.
Yeah. Okay.
It has to be surgery.
So it wasn't called, and then a year later, this is the TI. A year later, her appendix actually looked like this, and then you can see that, yeah, this distal portion is now looking to me like definite engorged, probably with mucin, but that there's this definite soft tissue component here, which is different than like the usual mucocele, like the low-grade mucinous neoplasms. So yeah, this was also, I think, mistaken for kind of bowel, and then she had this ovarian cyst next to it, and so also was not called here. And then unfortunately, by the time it was detected, it was metastatic here.
So it popped up?
What'd you say? It
popped?
Yeah.
Where did the mass go then? Like, where did that big ass like cancer go that was in the appendix? Is it anteriorly somewhere?
I don't think so. I was looking at this guy here. Maybe that's part of the mucocele, but it's blending in with these other small bowel loops. And then I think that all of this is the cancer.
Wow, really nice.
So just a couple of teaching points. So appendiceal tumors are generally rare. They're usually either carcinoid or mucinous tumors. They're less than 1% of GI cancers and are found on 1% of appendicitis specimens. We all know carcinoids can spread to the lymphatics and hematogenously, but this is kind of in this category of mucinous tumors, and these have peritoneal dissemination. So the mucocele, what used to be called a mucocele, is now called, it's kind of split into two categories. So there's either the LAMN, which is low-grade appendiceal mucinous neoplasm. This is the more common type. And then when this kind of ruptures and you get what used to be called pseudomyxoma, and they now call it low-grade DPAM, which is disseminated peritoneal adenomyomatosis. And then the higher grade ones, they're either intermediate or high grade, are actual mucinous adenocarcinoma, so not this low grade neoplasm. And that's when you get the actual carcinomatosis. So I think in this case, this was carcinomatosis from this mucinous adenocarcinoma. And then there's all these like other variants like X goblet cell, and there's kind of combinations where the goblet cell can produce mucin and not, et cetera. But just to kind of visually show the difference. So this is like the form of pseudomyxoma, now mostly called DPAM, where you get all of this scalloping of your liver, lots of fluid. If you were to take this fluid out, it's mostly just mucin, and it's very hypocellular. And these actually patients do much better. They treat them with HIPEC, they do quite well. Whereas this peritoneal mucinous carcinomatosis from an actual adenocarcinoma causes this more nodular peritoneal carcinomatosis rather than this fluid-filled one. And then these patients do much worse.
Now I understand, Aarti, that why you're asking me the differentiation between calling that a mucocele up front.
Yeah, no. I mean, I think it's great. I mean, at least if it had been called a mucocele at the beginning, it would have. But I think that it's like the higher grade version of a mucocele, where it's already this adenocarcinoma with invasion. They pathologically call it when you see invasion beyond the muscularis level, and that's when it's called like this more invasive one.
But I guess that's like the issue, right? Because at that CT where it was kind of not humongous, but just a little bit dilated, like that did look kind of, you know, just like fluid filled and otherwise unremarkable, right? Like no solid,
yeah.
Nothing.
Yeah. So I think like in this case, there was already probably invasive cancer here, hadn't like completely spread. And then probably this is some of that mucin because it is has a mucinous subtype, but it's not like the low grade appendiceal.
Not like what we consider, because then it also didn't progress onto pseudomyxoma or to, you know.
Exactly. Yeah. Which would have been.
Pop, you know, like, is that still the pathophysiology or does it just overgrow and infiltrate?
Well, what's the question?
You know how like the low grade tumors, they eventually fill with mucin and then the mucin pops. And then like you said, you know, there's mostly mucin in the abdomen, not so much carcinomatosis, but the adenocarcinomas that are mucinous type, you know, that probably invaded locally, like that peritoneal carcinomatosis.
Exactly. So I do think that it probably ruptured, but instead of just mucin filling the abdomen, it's actually peritoneal. Like these are actually tumor cells. Like it's much more cellular. So you'll see like actual adenocarcinoma here. So I do think that it probably ruptured, but it's not like just ruptured and making mucin. It's now just spreading like this. And actually, this have a much higher rate of also non-abdominal metastases. So it can become hematogenous. You can get like, you know, mets above the abdomen and stuff. Okay, there's some chats. Let's see. Victoria said she had to leave. Join. And the Sabi webinar. So tomorrow is that webinar. And I do have a couple more quick cases. Okay. This one, just a really quick one. This, we can see that the pancreatic duct is dilated in the tail. And then right here, kind of something's happening. And basically we have this fluid-filled structure that's going towards the stomach here. So, and then it's insinuating into the gastric wall. So my fellow was asking me, is this possibly like a gastric ulcer that's going down onto the pancreas? But I was telling him that, you know, this is probably more likely a disrupted pancreatic duct with you know, a fistulous connection that's kind of like eroding into the stomach. The patient did end up going for a pancreatic ERCP, and they showed that there was extravasation from this duct. So they placed a pancreatic duct stent, which is basically the treatment for a disrupted duct. This patient also has a history of acute recurrent pancreatitis. They've had about 20 episodes of pancreatitis. So we were also talking about that, how, you know, we're not really seeing a lot of findings of chronic pancreatitis here. We don't see like calcifications, but there is kind of this denser kind of more fibrotic part, I think, in the body here. And so, yeah, this was just a kind of unusual case where we don't really see all those changes of chronic pancreatitis. Manjul's asking if there was a prior cysgastrostomy, which there was not. And actually, I'm going to save my other case for later because my fellow has just arrived and I think I have to go do a fluoro study. So thanks everyone for joining. And yeah, there is a SABI webinar tomorrow if you want to join. And I'll see you guys later.
Thank you.